I must admit, I really enjoyed the first presentation, and it occurs to me that we have a teenager kid at home who is going to college in the summer, and at home we have Time Warner Cable Television, we have Apple TV, we have Roku, we have Amazon Fire and Comcast. But if you think I know how to switch between one to another, no. So I told my wife, the minute the kid goes to college, we pick a television channel and we're stuck with it for the next so many years, okay? So Steve, if you can find a way just to switch channels, we'll all be grateful, I think. Okay. It gives me really a tremendous pleasure to introduce Jonathan Rauch. Jonathan is a well-known reporter, contributing editor to the prestigious Atlantic magazine and to the National Journal. He's also a senior fellow at the Brookings Institute. Jonathan is an experienced writer on healthcare policy issues. I recently wrote a very nice piece, which I enjoy a lot, I plan to give to my students, on the value and the limitation of the greater integration of the American healthcare system. What's the value of all these merger and acquisition, and what are the downsides of looking at the future of healthcare delivery? Jonathan will be leading the next panel, which will be discussing overcoming barrier to disruption. So please give them a big hand. Thank you very much.
Thank you, Avi. Thanks to all of you for coming. Should my panelists come up? It's amazing to be here. This is a fantastic panel and group of people. Thank you so much to Ray, wherever you are. You're usually too tall to miss. And Ray's wonderful team for making this happen. I am a journalist. I am not an expert. I have written, as you've heard, about aging in place and alternative models to hospitalization. I've also written about disruptive entrepreneurship in healthcare and why that is beginning to take off. What some of you may not know is that I'm working on a book on age and life satisfaction. And in keeping with what Stephen just said, we often talk about extended longevity as a problem. You know, it's going to have all these people to take care of. Well, yes and no. It turns out there is a whole lot of psychology. One of the best results in the field is that for most people, on average, other things being equal, the emotional peak of life, the best years in terms of life satisfaction are when? Anybody? 20s, 30s? No, okay. We've got the AARP here. Yeah, so we've got a ringer in the form of Carol Rauch. In the seventh decade of life, as people decline physically, their life satisfaction actually improves because their values change faster than their bodies. What we have here is a gift. We're adding 15 years of life over the last century, and they're good years. So your challenge here isn't just to take care of the people who are sick and make that better. It's to take this gift of these 15 years, which are among the happiest in life, and make those the great lives, the great gift that it's going to be. We have an amazing group and not much time to hear from all these people. So I will mostly get out of the way. You can read people's bios in the brochures, but just very quickly, the reason it's an amazing group is that pretty much every sector is here. Elise Sweeney-Anthony is with HHS and does health IT work. It deals with standards and norms and is on top of what the government is doing and what's happening in health IT. Tom DeRosa is, if you're aging in place, it's about place, right? It has to happen in a physical location. And Tom is doing the investing and managing that is actually creating the places for the next stage of aging to happen. Walter Jin is a venture capitalist, private equity.
Yes.
Private equity. I get the terms confused, but I came away from an article, a Brookings report on disruptive innovation, believing that a key, maybe the key in making disruption happen is going to be the capitalists. It's the investors, because they're putting the other people together to make the deals happen, bring the money to the table. They're, in some ways, magic. Tom McInerney is Genworth, which is one of the country's world's, right, leading providers of long-term care insurance, and thinks as much as anybody out there about how to make these years healthy and happy. And we're especially grateful to Carol Raphael for being here. She's pinch hitting for the AARP. Deb Whitman couldn't be here today. So we're especially grateful to have Carol, who is chairman of the board of AARP, which is it still the largest group in America?
Yes.
How many members are you up to?
38 million.
Only 38 million members. I thought as a way to get started, we could just put some ideas on the table. We don't have time for long opening speeches, but I just wanted to ask folks, what disruptive change or what breakthrough would you like to see happen, and what are the obstacles to making that happen? And maybe, I don't know, Tom, let me start with you. I know you've given this some thought.
Yeah, I think that it's such a big area to focus on, but I would say the first is awareness and communication and collaboration. And it starts, I think, with families and individuals. And it's amazing when you do surveys how few conversations have taken place between multi-generations. I agree with Steve. It's an intergenerational issue between parents, grandparents, and children as to what are we going to do when our loved one needs help and services. So I think the first is really changing the way families interact together, and most importantly, that they come up with a plan for how that's going to happen. Then the second, and Stephen touched on this, there's so much innovation that comes from the private sector as to how you make aging better and improve the quality. And then finally, this is where I think the private sector and public sector working together, the costs of aging are unbelievably large. We're in Manhattan today, in New York State, the average annual cost, if you do have to go to a private nursing home, is $136,000 in the state of New York. In Manhattan, it's about $180,000. So the costs are enormous. I think families are struggling today. Their family members are having to do a lot of free caregiving, and on average, it's 20 hours a week. And so how do you take care of kids, have a job, plan for your own retirement, and then handle these costs, or just giving the free care? And I do think that there are various ways we need to encourage people to save more, plan more for retirement, so they take care of some of the burden on their own. And then ultimately, there's going to be a big place for entitlement programs. They're the only entitlement program that really covers these costs. Are the long-term aging challenges and costs is Medicaid. And, I think no American wants to ultimately rely on that program. In the Affordable Care Act, they looked at providing financing from the public sector for all these costs of aging. It didn't make it through in the Affordable Care Act, and so there's a lot left to do in terms of how do we, between individuals and their families, the private sector, insurance, whatever it may be, retirement savings, and the public sector to handle the huge costs.
There's a lot there. In your email to me, you said something interesting, which is that the change you wanted to see happen was not out there in the world, it's in here. You said a mindset change. Could you share with us what you had in mind?
Yeah, well, the mindset change is that we're all aging, and Stephen talked about the numbers, but it's going to have a huge impact on all the societies, and I really think individuals and their families really have to be thinking about these issues and how best in their families to solve the questions. But it's really about thinking long before you need the services for how you're going to deal with it.
Thank you. Tom DeRosa, you are trying to redefine place and how we think about aging in communities. Tell us a bit about that, where you see a breakthrough is needed and what might be done to stimulate that.
Well, to put it in the most simple framework, the number one issue we need to address for this population is safety. Safety is the element of a lifestyle that starts to become very acute as we age. And the historic home that people want to age in most cases, is not a safe environment for someone who has losing physical capabilities at the same time as losing cognitive capabilities. So it is that fall, most of us know this, it's that fall that takes your 85-year-old mother who still plays bridge twice a week, hits a tennis ball, drives to meet friends for lunch. It's that fall that happens one night in the kitchen that lands her in the hospital and starts a cascade of other health issues that, frankly, the cost starts to become unmanageable for payers, whether that's the U.S. government, whether that's private insurance. So we have to address that. And I think a lot of people here today, I mean, listening to Stephen and some of the things that Aging 2.0 is working on, what technology can do is start to perhaps create safer environments for people to live in place. Because Tom mentioned the cost of living with my company is staggering. I will tell you, the population of this island that we're on today is a little over 1 million people. If you have a parent who has lived their entire life on this island, who can no longer live in their apartment because it's not safe, because they have early stage dementia and they become prisoner of that apartment, and you start to see dramatic declines in their health and well-being. Their nutrition falls off, their mobility falls off, their cognitive engagement falls off. What are your options if you live in Manhattan? There are 70 private dementia Alzheimer's care beds on the island of Manhattan today for a population of 1 million people, 70. And if I took you to see them, you would basically say, pathetic, that is the option for my parent. And guess what? The average cost is about $14,000 a month. So about 10 days ago was announced that Welltower has purchased the corner of 56th Street and Lexington Avenue. And we will be building the Welltower, which will be the first advanced Alzheimer dementia care community on the island of Manhattan. And one of the things that's important about this is that it's actually taking this growing population and putting them in the middle of one of the most affluent pockets in New York City. So it's taking these people out of the shadows. They all live in the shadows today, and bringing them right into the corner of Main and Main, 56th and Lexington Avenue, a few blocks from where many of the people that will live here live today.
Now, you mentioned you've also got another model that you're working on called the Miracle Mile, which sounded interesting.
Well, the Miracle Mile is interesting, and I'm going to go back to something that David Feinberg of Geisinger said, that ultimately running Geisinger, which was one of the most progressive health systems in the country, he sees hospitals disappearing. There won't be hospitals as part of the Geisinger health system. And I agree with that. You've seen Mount Sinai here in New York having a full-page ad in the New York Times saying, if our beds are filled, we have failed. What does that all mean? Well, it means we have to keep these people out of the hospital. So in Voorhees, New Jersey, which is just over the bridge from Philadelphia, we partnered with the Virtua Health System to build an integrated healthcare delivery model that starts today with an acute care hospital, now it's a few years old, but a state-of-the-art acute care hospital, 300,000 foot, that is attached to a 300,000 foot outpatient medical facility. Because a lot of people will get their acute care needs addressed in that outpatient setting and never walk into the hospital. But if they do go to the hospital, when they come out, they will go to our Genesis Powerback facility, which is, again, connected, not physically, but in the same community, connected to the Virtua hospital system. And then it was our idea to bring a senior living company with capabilities for people with dementias and dementias, including Alzheimer's, to build one of our Brandywine communities right there. And so this, we didn't call it the Medical Mile. It was nicknamed by people in the area the Medical Mile because it's become a very connected example of how we can drive better outcomes in healthcare and do it at a lower cost. Because now someone who lives in the community at Brandywine who needs a knee scoped never has to go to the hospital. They can go directly from their residence at Brandywine to the outpatient center, to the Genesis Post-Acute Care Center, back into their home, which in this case, the home has been redefined. It's not the 4-bedroom, 3-bath house in Voorhees. It's actually the Brandywine Center.
It's a fascinating model. It kind of blurs that old division between the home and the hospital and bouncing between. I called it, by the way, wrongly Miracle Mile because that was the name of a delicatessen which we used to love when I was growing up in Phoenix, Arizona. It's Medical Mile. Walter, capital is so crucial in innovation, and there's a lot pouring in, but a lot more room for growth. Tell us how things look from a capitalist point of view. What kind of investment needs to happen, and what are the obstacles to making that happen?
There's a lot of capital that's waiting to be put into healthcare, primarily because we're at a point where the industry is going through dramatic transformation, largely due to the ACA. Not that the ACA was responsible for the industry moving, but it was the catalyst, certainly, where the industry decided unilaterally that we're going to change and try to move healthcare into the 21st century. But there are a lot of obstacles for finding those investments, those great companies that we're looking for to get outsized returns. Because with disruption and volatility, there are a lot of bad things that come out of that because it's a new risky model, a new environment, new competitive environment. But there's a lot of opportunity if you get it right for great returns. One particular industry that we're highly focused on is technology adoption within healthcare. But there's a huge impediment to deploying the technology that's being created throughout the industry because the payment structure isn't there to support the purchase of that technology. And a simple example, I'm an advisor to a lot of the incubators, Rauch Health, Startup Health, Blueprint, and Dream Adventures. And we see all these entrepreneurs with great ideas. And not all of them are what I call a need to have versus a nice to have, but there's still great ideas, great technologies that can help patients, help the system, help communication, connectivity. But we're here for investment. So if you do not have a commercialization plan, that doesn't matter that technology is great. There's no roadmap for you to actually sell it to a customer that actually has the capital to purchase it. So you can think all the low-end acuity settings like home care or nursing homes just don't have the money. Instead, what we've done is we put a $30 billion stimulus for EMR adoption for people that don't want it, right? Hospitals and physician clinics. Sorry, I'm going to offend like a lot of people today, but right? I mean, this is kind of like healthcare getting into the technology 21st century is, think back to the internet back in 2000, right? Where it was the internet, no one really understood what it was or how we're going to use it. We had companies like Pets.com, you remember that? And, Dr. Coop and all these colossal failures. And the EMR adoption policy is, $30 billion stimulus plus all the investment in the private sector. I don't know, just kind of colossal waste of money. I mean, I understand the need to digitize, data in order to do things later on for, data analysis, decision support. But our healthcare system isn't even at the point where, let's say we had all this intelligence from the data. We can't even convince our doctors to use it and change their behavior of practice medicine. So it's kind of like you're going down a path towards, frankly, artificial intelligence that the system isn't. What happened to just simple things like, I don't know, if I want to go find a doctor, let's just go to my insurance provider network webpage. Have you ever done that recently? You get a search, one zip code, 50 pages, and every doctor you have just no information. How do you find a doctor? I mean, it's the simplest things. Just message your doctor. We're in a world of text messaging.
One of the things that I thought I learned looking at health investment is when you're looking at the big federal bureaucracies and the hospital systems, you're talking tens or hundreds of billions of dollars with B to have an impact. When you're looking at private equity, startups, entrepreneurs, you're talking tens or hundreds of millions of dollars, orders of magnitude smaller to have a real impact.
Right.
I'd like to come back to you in a minute and ask you what could be done to unleash more of that capital in the here and now, but I thought I'd also move on to Elise, who actually sees this from the top down. How does this look to you? Is there a way that the government could become more of a change agent? And is Walter right to be skeptical about
I think that there's a balance, right? So to give a little bit of background, I work for the Office of the National Coordinator for Health Information Technology. So we are responsible for thinking about kind of the foundation elements of technology for healthcare providers and that benefit patients. So when you think about a patient who may live in New York, in Manhattan, right, during the summer, and they move down to Florida in the winter, what happens when they want to see a provider in Florida? What does that look like? Can their information be exchanged? What is the body of that information? How do you capsule that information and send it in a kind of quote-unquote simplified way of saying an electronic envelope? How do you get it over there and have that provider in Florida be able to open it, see it, use it, and integrate it into their system? So those are some of the fundamentals that we work with. When we first started thinking about kind of how to set up our certification program, and our certification program certifies certain health information technology. Some of it is EHRs, but we do it in a module way, so providers can work with their developers and say, this is the package that I need to benefit my patients, and put that package together into a system that works for them. We certify that technology, and that puts certain protections on it. We're saying, we look at it and say, and test it and see, okay, there are privacy and security pieces attached to it that need to be there. It's able to exchange the information effectively, and what's coming out on the end is working. So we work at those fundamental pieces. There are other kind of HHS arms that use our program. So they say, CMS might say for what's known as the Meaningful Use Program, providers have to use technology that's certified by ONC. So you're getting into this landscape where you do have health information exchange and certain information can move across the systems. Is there more work to be done? Absolutely. We released the information blocking report a year or so ago that focused on some of those additional things that need to happen. But in terms of kind of the next stage of kind of where we are in healthcare, where we are in health IT, a lot of that is actually happening. So a year ago, Congress passed the SGR fix. As part of the SGR fix is this little thing called MACRA that some of you may have heard of. MACRA, HHS released the rule that's going to accompany that last week. Monumental. Why? Because it focuses on quality. It focuses on that thing we're calling value-based care, right? So you're getting to that point where you're rewarding for better care, better health, not rewarding for the number of services that might be provided. And we worked very closely with CMS in developing that. And in both sides of that macro landscape, you have kind of what's called the merit-based incentive program, and that is still based upon quality, but a little bit closer to what providers know nowadays. And then you have this other area called advanced APM, so advanced payment models. You have model homes, model medical homes in there. You have ACOs, like that type of landscape, that more innovative space of thinking about the whole patient. Both of those call for certified EHR technology, but certified health IT, and having that right landscape of technology. Now, there's always going to be more work to be done, and our goal is to make sure we have the foundation in place. So in terms of thinking about, is that EHR helpful, right? So the privacy and security pieces that attach to it. We're now at a place where you have 90% of hospitals are actually using EHR. I don't think many people are saying, let's go back to paper, right? They're saying, let's make the electronic technology that we have, let's make that health IT technology that we have benefit me as a provider, and ultimately the patient. And that's what we're trying to move to. And we're doing that a couple different ways, right? So we have our work with our partner agencies to try to make sure that the technology is there. But we also have other resources, like we have an interoperability standards advisory. And it's published by ONC, but it takes in what we're hearing from stakeholders, from providers, from developers, saying, hey, these are the standards that are really helpful. These are the standards that would help me ensure that I, as a provider, have what I need and my patients have what they need. Because we focus not just on provider needs, but also on patient engagement. Can patient information be captured into an EHR?
What would you change if you could change one thing?
I think a lot of it is happening, right? So it's just starting to happen. The macro rule just went out, right? So I think that's a big piece of it, changing how, in the Medicare world, how care is rewarded. What are you rewarding? And you're rewarding the quality of care? Are you rewarding that health information exchange is happening to the benefit of the patient? I think that's where we need to go, and that's what's happening. And you'll see kind of my boss, Dr. DeSalvo, and CMS Administrator Andy Slavitt talk about this.
So, and you think this is underway. In 10 years, will things look very different?
I don't know if I would put a time frame on it. I think it's the MIPS piece, the macro piece, are all going to be parts of the innovation that happens. And it starts to spur change in terms of, as we work a lot with developers saying, okay, now that there's the part of that the structure of how you're rewarding care is changing, then ultimately the technology is going to have to change. Because in meaningful use, there was health information exchange, but in MACRA, you see it much more. You see the importance of exchange. So if you're rewarding folks, you're rewarding providers for exchanging information in a useful way that is secure, that benefits the patient, then you're getting to that place where providers are saying to developers, I need my technology to be able to do this.
And when you hear a real-world private equity investor who's out there on the street trying to get capital to the startups and the people making a difference, when you hear that person say, we're over-investing and over-prioritizing digitized records, what do you feel about that?
I think there's no, in my experience, there's no one item that changes a landscape. There's no one player, there's no one piece of the puzzle. It's the whole picture that we have to look at. So I think absolutely that what is happening at HHS in terms of the foundational elements for health information technology, what's happening at CMS in terms of MACRA, those are pieces of the puzzle to
all
get
of the
us
above.
to there. Right, and then there's also a place for innovation. So, and that's what we want to do as well. So at ONC, we recently put in a certification criteria related to application programming interfaces, right? So APIs. We all use them in different phases of our kind of everyday life, but in healthcare, they're still becoming part of the puzzle, right? A lot of innovation is happening outside of the government on that, and we love to see that. So what we put in our rule is a functionality. We would love for the developer that's coming out to us to be able to have this functionality. But the criteria, the standards that are attached to it, we didn't include that because we want the innovation to happen outside.
So we'll take that as a challenge to the people in this room.
We actually do have some challenges. I'm glad you mentioned that. So ONC actually has some API challenges that are out right now, and that's to bring the stakeholder space in and to say, hey, this is how APIs can be used for patient engagement and a couple others. So check it out.
Thank you.
Thank you for the commercial.
Completely unintentional. So Carol, you guys are walking the walk. You're dealing with the folks by the millions every day. What needs to be changed, and where would you start?
Well, I'm going to focus through the consumer lens on 3 priorities, and I've kind of built on something that Tom and something that Walter said. I think the first thing is to really enable people to understand quality and make good choices. And we talk a lot about big data, and there's an enormous amount of data out there, but the average person hasn't a clue as to how to make good decisions about what physician to see or what hospital to go to for surgery. And only 2% of consumers use the 5-star system that CMS has, or any of the other systems that are out there. And I also think part and parcel of that is thinking differently about quality. We say beauty is in the eye of the beholder. Well, we have to stop defining quality solely as clinical results. We have to also think about what people value, which is their waiting time, how they're treated, whether they're listened to, whether someone gives them information that they understand and can act upon, and what the experience is like for them and their family. So that would be number 1 for me. Second is the whole need to kind of enlarge the frame for healthcare to include a number of elements that are not traditionally part of our healthcare system. One of the things that we were very surprised at AARP was the degree of social isolation that quite a few of our members are dealing with. They lose a spouse. They begin to lose their colleagues, their friends. They become more and more cut off from what were their kind of family and community. You know, very few families live together the way they did when I was growing up. And 17% of our members experience social isolation, and it very much affects their health status. We've seen that it begins to decline. So I think we really need to think about different ways to involve people in their community and to set up peer networks and connectivity. At AARP, we took on the Experience Corps. I don't know, many people in this audience know what that is, but it gives people in their later stages of their lives a chance to go into schools and to teach and tutor people, young, usually in an elementary school, really tutor young people and help them to learn skills, to read, write, etc. And it is one of the few interventions I have seen, and we talked before about how to do control group studies and whether or not that makes sense, but this has shown that for the people who do it, their health status is much higher, and for the students, their achievements have been phenomenal. So that to me is an intergenerational program that benefits the entire community. And I sit on the Age-Friendly Commission in New York City, and we have been working on things that you may think are really not that important, but matter a lot. We took all the courses of all the universities and put them online in one site. So if you want to study art history or you want to study something in technology, you don't have to get an NYU and Columbia and Hunter. You go to one site and you can see all the offerings, because people now want lifelong learning. It's not just learning for 4 years when you're in college. We helped design the new taxi cab so that people could get in and out of the taxi cab. We made the numbers last longer when you cross the street. And what was different there was that we were at the table in designing the programs for our community. We didn't inherit it. We helped to create it. And I think that needs to happen much more. And then thirdly, something that Tom, you said, I really do believe that people are ill-prepared for the later chapters of their lives, and it affects entire families. And we know at AARP, and I find it stunning, how little people have in savings when they move out of a full-time work environment. And you see different studies, and on average they have between $25,000 and $50,000 in savings. And at the same time, and I sat on the Commission on Long-Term Care, and I found out that 70% of Americans are going to need long-term care at one point in their lives. This is not a marginal issue. This is a mainstream issue that's going to affect all of us. And it's very expensive. We don't have much private insurance coverage, as you well know. We don't have a public insurance program. And it affects an entire family and their well-being. And we know there are 42 million so-called informal caregivers as we sit here today, trying to help provide care to a relative, a friend, or someone in their network. So I really do think that we have to work in two domains. Long-term, to think about how we can better prepare and keep people secure. And short-term, I get calls every week from people who say, my husband broke a hip. He is now in the hospital. He has to leave the hospital today. What should I do?
Yeah.
And
this room is full of people who face that
exact situation. And I got a call this week from someone who is in the state legislature. Do you think this person was sophisticated and knew what to do? And hadn't a clue as to what to do, how to get help, what the options are, and what would be the best road to travel. So I say, let's begin to use technology to solve some real problems that are facing people today.
Tom?
Yeah, I think one of the problems is that people, still think that Medicare is going to pay for that parent when they can no longer live at home because of dementia. That there is, I often, when I speak to groups, because we take care of these people, I'll ask for a show of hands. How many people think when your parent who broke their hip, who has dementia, is going to live the rest of their lives in a funded by Medicare in a nursing home? And a lot of people believe that. Even esteemed publications like the New York Times write articles where they interchangeably use the word nursing home and assisted living. Nursing homes do not provide housing, long-term housing for people who have dementia and Alzheimer's, only if you're impoverished and you go live in a long-term care nursing home for the rest of your life. And most of us would not see that as a good option for anyone in our family. So I think there's so much misinformation out there. I think organizations like AARP can help people understand that this is something today we need to take into our own hands. The government is not going to pay for your parent who has dementia.
Tom McInerney, people at Brookings look at this and say this is a ticking time bomb.
Yeah, look, I think there's no question that if you just look at the regular entitlement programs, so take long-term care and taking care of aging Americans, put that to the side. The unfunded liability, if you had Social Security, Medicare, Medicaid, and the Veterans Administration, it's like over $100 trillion. And I've looked at various studies that say, in 20 years, when all the baby boomers will be over 65, less than 10% of the U.S. budget can go to anything but entitlements. And that's with, as Tom said, long-term care not being covered. So, and that was one of the problems with ACA. I mean, I think the Obama administration correctly tried to, through the Class Act, provide some public funding. But looking at all the current unfunded entitlements, to add that onto it, it's something like $450 billion a year is spent, mostly by individuals.
For purposes of argument, let's stipulate that the government's not going to ride to the rescue and write a big check. What other alternatives?
But here's where I totally agree. The problem is that individuals and their families don't have enough money. Only 8% of Americans have bought long-term care insurance that covers these costs. Regular health insurance doesn't. So the government has to, because I don't think we're going to allow in this country, you saw the numbers, it's like 50 million people needing these kinds of care in 20 years. We're not going to say we're not going to do it. So the government has to. But I do think we've got to put more incentives. One thing that both Brookings and the Urban Institute and the Bipartisan Policy Center said, let's offer long-term care in the work site, and just like we do for 401k and have people opt in. But I think my own view is the government is going to need to pay 70% of these costs. Right now they pay 7-0. Because
good luck with that.
Because it's too late for the baby boomers are 75 million people. It's too late for them to save. The average saving is between 50,000 and 100,000. I think as Tom said, if you're in Manhattan, 14,000 a month is, basically your savings would cover you for 3 or 4 months.
Walter,
it is a big issue, and the problem is that we've kicked the can. The individuals, family, personal responsibility, the private sector, the public sector, kick the can down the road, but now we're facing this deluge of these baby boomers. The oldest is 70, the youngest are 52, and every year they get closer to around 80 when all of these long-term care and people's inability to do the activities of daily living that we're talking about, it's really right there.
Walter, do you see profit-driven solutions to these problems, as opposed to government writing a $400 billion a year check?
Yeah, it's there. I mean, technology is already disrupting healthcare, despite whether there's federal or government monies or not. Thank goodness we have a commercial sector for insurance companies and payers and HMOs, and there's a lot of activity where there's money to be had because there's so many inefficiencies in the system, right? I mean, let's just start with, for example, what's the leading causes of death, right? I mean, there's heart disease, cancer. What's the third? Preventable medical errors, right? Harms. Preventable medical deaths is the third leading cause of death in the United States. I don't hear about anybody. I mean, you mentioned safety, right? I don't hear about anybody in the government talking about how to incentivize not killing people by mistake. But there's a lot of technology out there that is geared towards safety protocols, and thank goodness our commercial payers will pay for that, whether they're going to pay for it or they're going to let someone else take risk and assume that responsibility through technology assistance to save people's lives. It's already happening.
So I think that, on the safety part of it, there are, at ONC, we actually have an entire safety and quality and safety division. And in our rule, when we look at certification criteria, there are elements that are attached to safety enhanced design. So we do try to think about that, at least in our sphere of that foundational set of health IT that's required for the programs. The other thing I want to touch on is the care coordination aspect of it, and that's something we've been doing a lot of thinking about. We have 2 federal advisory committees, one that focus on health IT policy and one that focuses on health IT standards. And we've looked in the past at long-term post-acute care and also behavioral health, but to see what are the health IT needs in terms of what's needed for certification for that group. And what the stakeholders who are part of these federal advisory committees said, and they're stakeholders just like you, from industry and providers and patients, said is that, it's transitions of care, right? So if I'm in an acute care hospital and I get transferred on a Friday night to a long-term post-acute care facility, and they can't take the information that the hospital has in their EHR and transfer it over to that skilled nursing facility or whatever it is. And I have to wait till Monday, till someone opens their email and sees what my medical allergies are. So those are the things we started to think about. And we've updated our program to an extent to allow for more module-based certification. So a long-term post-acute care facility could have a system that pulls that transitions of care module and uses that so that you get to a place where different settings are able to communicate effectively to the care of that patient. Because, we've had stories where folks come to us and they say, here's the bag of medication I take in everywhere I go to see my provider, right? Or here's the packet of information I have to take because it's not transferring. So that's part of the conversation. That's part of what we're looking at and trying to bring into what we're doing at ONC. And I know CMS is also considering that as well as they look at MACRA and so forth.
Let's go to all of you. I had, by the way, that exact scenario with my father, who was hospitalized needlessly for 3 days just for a test that he should have been in and out that afternoon because the medical record was locked in a file cabinet in Phoenix, Arizona. And he walked into that hospital and he left in a wheelchair, having lost his mobility. It's just awful. So this happens all the time. Something else, just a quick comment on part of what I'm hearing is that when I looked at what entrepreneurs are doing, what was interesting about it is that they're approaching it from the angle of disrupting the idea that you have just 2 settings. You're sick at home or you're well at home, and then you go to an institutional setting, which is a hospital or a nursing home or long-term care, and you're planted there. They're wiring up homes so that this distinction can be, they're looking at whole new ways of defining the problem, which I thought was just deeply encouraging. Sir.
Thank you. Can you hear me? So the topic of this panel is barriers to disruption.
I'm sorry, could you introduce yourself?
I'm sorry, I'm Mark Goldberg, and I'm from an elder care startup out of Red Star Ventures in Boston, Massachusetts. We're focused on tech-enabled services for caregivers and their loved ones. And we're very sensitive to the issues that Carol has mentioned and both Tom's about having the conversation and about planning and trying to maintain independence. And we have about at least 10 great ideas of things we can do to change that world and do something different. We would have 10 more if the government could help knock down some of the important barriers. So I've worked in population health also for a long time, and I've found that I can't count on providers or EMR vendors, whether they be Epic, Allscripts, Cerner, or the other players, to really push interoperability. They're interested in closed systems and market share. At the same time, ONC and the ACA have pushed HIEs and HIPAA, and there are issues that really hold back some of the neatest things that we want to do. Since I can't trust the providers and the EMR companies, why can't we have more paved roads for consumer-mediated, and this is a legal term, consumer-mediated requests for data for the family and for the consumer so that they can manage their data and move it where they want to move it. HIEs have been, except for a few nice exceptions in Oklahoma, Indiana, maybe Maine, a couple of other places, colossal failures. And God forbid you should want to get consumer-mediated data out of them. It's simple, even not an EMR record, just an HL7 message would be nice. I mean, we could do some very, very interesting things with it, but it's just not possible. Short of that, maybe a single patient identifier so that maybe there could be one big HIE in the sky.
So I think that's directed towards me. So you touched
we'll let you take that question.
you touched on a lot. So One, in terms of HIPAA, we actually have a Chief Privacy Office, and they work very closely with Office of Civil Rights, which manages HIPAA at HHS. And that's been a big focus for us, is really understanding HIPAA. So what we've called, there's this blog series, if you guys want to check it out, it's called The Real HIPAA. And that's exactly why. It's because there's a lot of misunderstandings, I will say, in terms of what information the patient can get. So we actually released a blog series that talks about exactly that. And it's written so that different audiences can understand it, whether it's patients, whether it's providers. And we've heard stories, like I actually just had a scenario where my daughter's pediatrician was saying, well, I can't send you that. I'm like, nope. Yes, you can. Let me send you the guidance. So it happens. So we actually are trying to address that so that people understand what HIPAA does, and that HIPAA is actually an enabler for patients to get their information. It does not prohibit, patients have the right to get the information however they want it. That's it. So take a look at that. That's a good resource. I think we called it The Real HIPAA, but if you go to healthit.gov, you'll easily find it. I can't believe the number of commercials I'm getting here. But anyway, the other thing I want to mention is really thinking about the information that's moving and the access that patients have to it. So we're doing an update to what we have, this model privacy notice. And we did it in the past, but with all the new technology and the innovation that's happening, we want to make sure it's up to date. So we put it out a request for information on what folks think should be in the model privacy notice. Our hope is to get that published. And what that would be is a resource online where companies, whether it's like a app developer or it's a facility, they can create or fill in templates to create a model privacy notice so that patients actually have the information on how their information can move. In terms of health information exchange, it still continues to be a key part of the conversation. And we issued a report, like I said, the information blocking report. Congress asked us to do it. We took it very seriously, as we take all reports. And we actually put together, hey, this is what information blocking can look like. And it can be providers. It can be developers. It can be different players. It could be healthcare, large hospital systems who are blocking the flow of information. And that's something that we look at in some ways agnostically. There can be a number of different players who are information blocking, and that inhibits the care of the patient. So in the macro rule that was released last week, there is an information blocking attestation. So if you're getting paid under Medicare, we are proposing that you would have to attest that you are not information blocking. And it's a very clear three-part component to what that means. So we are trying to address that in a number of different ways. And then the last thing I will say is that in our rule, in our last rule, which we released in October of 2015, we have information on transparency. So there's more information available to the provider about what the vendor is going to require of their systems, right? So a lot of what we hear is that I don't know. I don't know how my information is going to be held up or what charges I have to pay for health information exchange. We're asking that the types of costs and more information about how that product is going to work with the provider be disclosed so the provider can make a more informed choice.
Would anyone else like to comment on any aspects of this?
I mean, I think my own kind of thought on the barrier here is that government rightfully regulates healthcare to an enormous degree. It's a highly regulated sector of our economy. And government does that to ensure that both employer dollars and taxpayer dollars are spent appropriately and to protect people. But I think somehow we're in an environment where we need much more flexibility. So if we introduce an intervention, I think it's important to be able to evaluate that intervention in 6 months and modify it accordingly. But we have a model now where we have a demonstration. You do the demonstration for 3 years. You have an outside evaluator come in, evaluate that demonstration, and then in 5 years down the road, you'll know whether or not that intervention had any impact. And it just doesn't give you the fluidity, which I think you need when you work in the healthcare system, to constantly get feedback from the people on the front lines, from consumers, and modify that intervention sort of in real time. So I think that's going to be one of the challenges, and trying to find a way to make our whole system much more flexible.
Well, one other thing, just quickly, we're talking about disruption. I totally agree with what you said about the need for regulation, and healthcare is very much regulated. However, these regulations have been piled on top of each other over 30 or 40 years, and so it is somewhat ridiculous. And I'll give you just one example. If you want to consider buying a long-term care policy from us, on the applications, it's probably now about 100 pages. Now we're trying to get it all electronic, and you need 18 signatures for an application to get long-term care insurance. Now, there are reasons for that. It's privacy, all kinds of things. But ultimately, that you make it so hard. A lot of times we have people said, I'm just not going to deal with it. So I do think regulation is critically important. But we've got to look at the state level and the federal level, what are all the regulations? Who understands all of them? And then let's redo it all, disrupt it all, so we get regulations that are much more streamlined, much easier to follow by all the parties in the healthcare system, from the patient to the providers. So the safety is there, the protections are there, but it's much more efficient and it's much lower cost.
Sir.
Al Cannell
Thank you.
from Rochester, president of Strategic Interests, a consulting firm that helps organizations with HIT strategies. And all is not lost. Just up in Rochester ourselves, it's not perfect, but we do have a combination of private and public HIEs that enables transition of care of information as patients go from one site to another, from hospital to long-term care, et cetera. However, we have to make major change, and the new funding that ONC has put forward for helping actually address that will be significant. We are working through, as part of a program called DSRIP, which is for the Medicaid population, not necessarily the population of this segment, but it will be putting in the infrastructure that will enable liquidity of information that will be helpful. We would like to work with you because we've looked at those transitions of care and what's required. It's far above what meaningful use has said. And we need some clarity within our community about exactly what information we want to share. Great. I guess the question, though, is where and how do we take these different initiatives, these different technologies, these different pieces, the capital behind them? If you have a population health program that's connected to payment and connected to somehow or another getting folks to coordinate all these initiatives, it might have a chance at being a set of solutions that are cohesive. Without it, it's going to be whoever's buying something getting whoever's selling something to hopefully get a match. So how do we get perfect markets? Or I'm not a utopian, but how do we get better at collecting these disparate initiatives and technologies to help the whole thing? And you have population health for diabetes and different diseases. Why not population health for people that are aging?
I'll take a stab at that. I think we need to provide incentives for people to maintain wellness in their lifestyle. And it's very difficult as we age to maintain wellness in our lifestyle. And the burden of that completely falls on the individual and their family. There is no government reimbursement for maintaining wellness, and that is nutrition, it's mobility, it's safety, it's cognitive engagement, as was discussed here. As people start to become isolated, their health and wellness declines. Yet, again, the burden of this is all on the individual today, whether they have insurance through Genworth, which is the only reasonable insurance option today for a family or an individual. This is a problem. And at some point in our lifetime, I hope, there will be incentives, whether Medicare will pay the portion of the cost of housing for people who are cognitively impaired, to keep those people out of the hospital, because right now we're just waiting for them to go to the hospital, and we'll pay everything once they go to the hospital. But we won't pay to keep them out of the hospital. At some point that might have to happen.
So how about...
Or tax incentives for the families that are paying to put their parent in one of my residences to keep them out of the hospital, which is saving the government money.
How about the existing model that's emerging of population management, and we're seeing more and more provider systems that are looking for ways to keep people out of hospital, keep them healthy, and we're seeing an ecosystem of entrepreneurs who are starting to build models to help them do that. Is that making a difference, or? basically not.
It is making a difference. The example we talked about earlier in Voorhees, New Jersey, there is data. Johns Hopkins is going to be looking, I see Bruce Leff here in the audience, they're looking at our population, and they're collecting data that will demonstrate that people that live in alternate settings, people that live a wellness-oriented lifestyle in an alternate setting, are actually making fewer trips to the ER and staying in hospital beds have shorter length of stays. That means real savings. So that's an example. But it's very early days.
And I don't think we've yet seen at scale anything like a model of population health that's directed toward an aging population. I mean, we already know that dealing with a geriatric population in general has not been an attractive option for people in the healthcare field, and that they will often gravitate toward a specialty or an area that offers them more glamour than dealing with someone who has incontinence or depression or mobility balance issues. So I think we need to think about a population health model that builds on the assets of older people who fervently want to remain as healthy as they can, as connected as they can, as active as they can. And we have a model now that's very attached to deficiencies. I call it a deficiency model. We zoom in on what's missing, not what's there. And I think that population health model has to have a very different perspective.
Thank you. Yes, over here.
Hi, my name's Amanda Christini. I am the co-founder and chief operating officer of a company called Blackfin, which is out of the University of Pennsylvania. We develop products, a software platform to integrate and analyze complex neurologic data for better drugs and devices. But I'm also a physician, and so I'm going to ask my question with that hat on, which is, I'm an internist, I'm not a geriatrician, but I take care of a lot of older adults in the hospital, so I don't do any outpatient practice. And so by definition, I see some of the failures that we're talking about. And we've talked a lot about wellness and longitudinal care. Haven't talked much about end-of-life care. And when we think about how resources are allocated, in a healthcare system that was built to take care of patients in an acute care setting, disproportionate amount of those resources are spent at the end of life when, if we think about quality of life, certainly not how most people would envision their final days, weeks, months. I do a lot of palliative care and a lot of hospice. So I guess my question is, how do you think about that problem and potential solutions there? And is there anything being done, I guess, at the policy level or at other levels that you think have moved the needle in terms of starting conversations around end-of-life care earlier and sooner? It is incredibly uncommon for me to encounter a family that has ever talked about this before it's upon them and they have to make a choice.
And despite everything, hospice is still underutilized and actually gives better results than intensive medical treatment. Who wants to take a crack at this?
Just to start, I think it's a big issue. And I think it comes back to having the conversations within the families. And it starts with the person who is aging and what do they want. And what we find is in very small percentage of families have actually had the conversation where the person who is beginning in that journey to the last stage, what do they want? And do they want to be taken care of in the home and not in an institutional setting, or they're fine with that? Who are they willing to allow to care for them? Does it have to be a family member or a neighbor, or can it be a professional? So I think there is the need for the conversation. One of the things we're doing is, when it uses technology, is we have this Genworth aging experience where we've come up with this R70i suit. And it's gotten some press where you can actually, it's got goggles and hearing and a whole body suit. And so you can, and it's all computerized, so you can, if you're a 25-year-old, you can see what it feels like to be 80, 85, or 90, and all the things that will go wrong. So you have a better understanding for what it's like. And I do think ultimately it's the individuals and their families have to decide what is best for them at the end end of life, because you're right, the costs are very much tilted for that. I think it's going to be hard to have because everyone has different views. Some want to live as long as possible. You hear others who say, no, I don't want any artificial help. And so, but I think that the conversations just aren't being had generally across families.
We have 2 minutes and one more question or so. If you can ask a quick question.
Yes, Nancy May. I'm from Reading, Connecticut. My business is totally different. I work in the public company boardroom, but I've been forced into the healthcare environment or thinking about it because my own parents care. My dad's 96, my mom's 87, dealing with a lot of issues. I've been through the independent care, the long-term care. I've moved them out of that. I have running my own agency with 6 independent aides on my own, figuring out what to do. I mean, I guess I'm the ultimate entrepreneur, saying, okay, now I'm building something on my own. Inadvertently. But,
I need to ask you to get to the question.
So my question is, and we were talking about the technology and the bigger issues that are going on in government, but what I'm seeing it's missing is really what's happening at the less, I don't want to say intelligent, but the less educated caregiver side, and what's going on between people like myself who are dealing with caregivers, and how do you go through this process? Because we're drinking from a fire hose, and there seems sort of like there's a missing gap. And I'm not exactly sure if there's an opportunity to work with those people and ourselves or not. I'm not sure.
Briefly, we, at AARP, trying to support caregivers is one of our major priorities. And I said before, there are 42 million caregivers on any given day in the United States. And we know that they pay a great price. Many of them have to leave their jobs, and it takes a psychological toll as well. And I just found out, to my surprise, we think that it's typically a 49-year-old woman. 40% of caregivers are men. 20% are between the years of 18 and 34. So we have passed the CARE Act in, I think it's 20 states now. You would think this is simple, but the CARE Act requires a hospital to include the family in the care team, to instruct the family on any kind of tasks that have to be performed because families are flushing catheters, dealing with major medication regimens. And so we are working on that, and we've also put a bipartisan coalition together in Congress because so many members of Congress themselves are caregivers, to really begin to figure out a national strategy.
This is a huge underwater part of the iceberg, the caregiver invisible workforce. Thank you all. It's been an amazing session.